And they can also in the bottom on the right, and they'll see even if they put on their phone, they can send you a little thumbs up or whatever to let you know that they're in and working well on the Menti.
Okay. So again, we're trying a little something new today. We have some polls, menti.com. Use code 912-15737. And also, I know everybody is pretty much used to putting your name in the chat if your name doesn't show up on the participant list and you're a little like numbers. Just make sure you put your name in the chat. And the website name is Menti, MENTI.com, MENTI.com. Code 912-15737 when we get to the polls. And you'll be able to participate in the polls then. And they'll show up on the screen if you've ever done polls. So thank you all for doing something new. Again, repeating that I'm apologizing that I'm not on screen because I'm out of town. So I don't want to lose my signal for this presentation. And you can see on everybody's muted as you come on. So if you do want to unmute to say something along the way when we ask for comments or anything, *6 should unmute you, but then make sure you mute yourself again. All right, next slide. So everybody, welcome to the Rehab Forum for today on April 23rd. Today's agenda, we should be able to get through it pretty quickly, but welcome to everybody. You see that we have a few little things, and that's good, Christina. Christina's running our slides today. Again, it's still April, which is OT month. So again, congrats to all our OTs and OTAs out there working hard in the fields and in the office as well. Thank you all for everything you do every day. And next slide. Okay. So we have a little fun little poll. This is where we're going to start our polls. So in honor of OT month, please enter the name. This is where you should be on menti.com. Code 912-15737 to participate. Please enter the name of one of the OTs or OTAs that you've collaborated with recently. Oh, Roberta, Ellen, this will create a little word cloud for us. So thank you to all those OTs, OTAs out there. A little fun way to get started today. Amy, Kara, you guys are doing a great job. Thank you. Hey, Christina, quick question for you. When we put out the slides, will the word cloud show up so everybody can see the names of the OTs that have been entered?
It will. It'll have, I can do that for you.
Great. Thank you so much. Thank you, everybody, for participating. All right, we'll end that right now, but this will show up on our slides. These slides will be available online. Thank you to all the OTs and OTAs out there. We do have a contest that we're going to do too to honor OT month. It'll be a contest for all of inpatient, outpatient, home health. So around 12 noon today, the contest will go up on the rehab site, on the rehab DWP and the home health DWP. The contest will stay open from this Tuesday to next Tuesday at noon when it closes. We want you to take a few minutes to learn a little bit more about OT and take a chance at winning a gift card. So to honor OT month, you're going to be able to answer a few questions in this contest related to OT and healthcare. I'll say they're probably not really easy either. So anybody submitting the correct group of responses regarding the OT questions will be entered in a drawing for one of our 4 gift cards. So a little fun way to learn about OT and maybe win a prize. So again, that'll be open from noon, April 23rd today, to Tuesday the 30th. It'll be posted on the Rehab DWP and the Home Health DWP. And we'll announce the winners by the May 2nd. All right, thank you, Christina. And here, just to remind everybody, another thing coming up, thinking about our rehab teams, May, which is just like, 8 days away, May is Better Hearing and Speech Month. So then we'll switch a little bit from honoring our OTs to May for Better Hearing and Speech Month for our speech language pathologists. So make sure you reach out and wish them a great May. Thank you. Just a really quick little patient story that came from one of our market meetings where I asked people to write down any quick little stories they had. And this was just about making a difference. So no names or anything like that, but it was about actually a PT and OT, so I apologize for the typo, a PT and an OT working together that really worked on how they could help the patient transfer education, how to align safety and positioning in a co-treat. And they were able to actually assist a patient with paraplegia in and out of the shower, first through shower in months. So guys, think about how important that was for this patient and what a great job and a difference our PT and OT made working together. So kudos to whoever the PT and OT were working together in this case. Truly appreciate everything you did. And I know showering, I mean, just think of that daily task, how important. Okay, just a reminder, everybody, this is just again, these PowerPoint slides will be available on our DWPs probably by tomorrow. And the home care forums coming up, like I've made the rehab forums right now, they're going to be Zoom only. So call in for these rehab forums because we switched a little bit to trying something new. The next slide. One of the things that came from meetings and discussions was the team members were mentioning they wanted me to get out to the markets a bit more. So I'm out meeting in the markets with people. So you'll see on the screen, these are our dates and times. You'll see the market right in the middle. So each market has 2 meetings coming up, one June and then one right around August. Trying to do it every couple of months, get out to the markets and meet with people. And we've really made a difference already from coming from the market meetings. And you'll see that later on in the slides on some updates from the meetings. And I'm trying to keep those meetings. One of the things that came up in, I think it was in Central's meeting here, was the point about trying to be consistent. So my slides really follow at each market, just we get different ideas from each market of what's going on in their teams that actually can help our whole rehab team. And you'll see that again. So we'll get to that a little later. So right now, some updates from across the system, things that may make a difference, and some home health referrals that might touch us. We are opening a new site out at Amherst. A little far out for our teams, but knowing that you may get some of those referrals past Sheffield area, past Avon. We are opening a new clinic for outpatient. May 1st is the first patients planned, and that is, you'll be seeing a couple pictures here pretty soon. If you're anything like me and are very visual, I have some pictures as well. And the rehab numbers in here. So in case you needed to get a hold of the supervisor or manager out there, they're listed as well. I'm trying to give you guys as much information as possible for connecting. The other thing that we're doing is we're working in an outpatient basis on a multidisciplinary post-concussion clinic for return to sports. You know, that might affect those home health referrals when you're seeing the younger ones out in post-surgical. You might be kind of networking and talking to outpatients about that. And then for the peds market, we had a hold on our business plans in quarter 1. So the West Market peds would still be getting home health referrals, maybe a little bit more than usual because we don't have our outpatient clinic right now out in that area. They're traveling to Rainbow or to our temporary clinic a couple of days a week that we're having at St. John's. But that's limited on the patients we can see from an outpatient basis. So that is should be affecting the home health referrals with more referrals. Hoping to reorganize with our strategy team on the business planning. So more to come on that as we move forward. Next, will Amherst have PTOT and speech? Great question. They are going to have PTOT and speech at Amherst. Speech will be in there a couple of days a week. PTOT will be in there 5 days a week. So great question. Amherst building, you'll see up on your screen if you have your screen up. Amherst Healthcare building is really taking shape. If you saw the pictures from before. And the services that they're going to have there are radiology, lab, peds, OB, rehab, at Harrington Heart and Vascular Institute, and some primary care. And on the second part of the building, they have surgery as well. So this is actually, the rehab suite is almost done. We should be moving things in next week. What you see on the screen is the gym is off to the right. And if you look up in the screen, one of the neat little features, if you're talking to patients about going to outpatient, on the west side is there's actually a lift system. So we're treating orthopedic and some neuro. That'll be more like the specialties in that clinic. Of course, treating general as well. But we do have a lift system that's been installed for this clinic. And that'll help with our neuro patients. And next, this is the slide. So on the right-hand side, when you approach the building, is our medical office building, health center. And on the left-hand side is actually the surgery center, which is a whole, if you looked at it's a whole little network of groups that got together and created the surgery center. So there'll be surgery right there on site, so the outpatient surgeries. So like your hip and knee, shoulder surgeries, things like that could be taking place here at this surgery center out in Amherst. So really helping a population that, getting further west with our university hospital patients, able to offer more patient access. All right, Mary Ann, are you out there? You're on for your slide next.
Here I am. Yeah. Good morning,
All
everyone.
right.
Thank you, Dottie. Yeah. I'm so happy to be able to talk about this. At our central meeting, we were discussing additional opportunities for engagement. And our team identified this, and we wanted to share it with the whole agency so we could form a work group. The opportunity is to improve the library of patient education materials used by Rehab. As you know, or we have electronic resources on the DWP, we have resources on paper. We also know that individuals have their favorite exercise programs they'd like to give out to folks. And the idea is to make sure that all our materials have our logo, they're current and updated. We want to make sure that we have all locations identified for this information and then how to access them. So we're seeking people who would be interested in joining this work group. One additional piece that Dottie shared with us is that she has access to the MedBridge program, which, as you probably know, is a home exercise program where you can customize programs per patient with hundreds of exercises available. The inpatient and outpatient rehab therapists have access to this, and we can too through Dottie. So for this group, we'll have to develop a strategy on how to do that, but we have access to that body of materials as well. So if you're interested in joining this group, we're asking that you send an email to me and to your manager, and then we'll identify the group and get going. Are there any questions? All right. Thanks much.
Oh, thank you, Marianne. This is a great project too. We know it's been a question about how we can update things. So this is great. All right, Wanda.
Good morning, everyone. I just wanted to take some time today to review and refresh our home care supervisory visit condition of participation with our upcoming anticipated Medicare survey. And with the change to Epic, we just have to ensure that we're meeting compliance in the areas. So as far as the condition of participation, PTs, OTs, STs, or RNs must make an on-site visit to the patient's home no less than frequently than 14 days for a supervisory visit. There were some supervisory visit audits performed in the beginning of 2024. And as you see, as far as the data on the screen, we're not that compliant in Epic as we were in home care home base. I know that there's a lot of factors that are coming to play in this, and I do believe there actually is a work group scheduled today, this afternoon, even speaking regarding the supervisory visits and also the template as well as far as the plan of care. But as you can see, we are not being compliant as we started in January at 60%, and then currently in April it's 0% compliance. I do have to state though that the numerator is low in these areas, and that the clinicians also have been reached out to in real time, just to inform them about supervisory visits. Now, the thing with the supervisory visit form, it has to be added to the visit. It doesn't automatically come on. So you would have to go to add form, add the supervisory documentation, and then I just added the clip actually from the Quick Start Guide on how to actually add a form. It's really integral in Epic. I know there's alerts, but there needs to be that communication interdisciplinary between the team members to ensure actually the supervisory visits are done every 14 days. So communication is a key as far as, who's in there, who's able to do them. Because we will, as far as an organization, if we will get, when we have our audit, and if we're not demonstrating our compliance within this issue, then this will be something as taken as a deficiency, and then we'll have to do a plan of action. So we're really trying to just figure out the best way in Epic with our documentation to ensure that supervisory visits are performed every 14 days. That's all I really wanted to bring forth today.
Thank you, Wanda. And thank you, Wanda, for all you do. I can't even imagine all the work that goes into our quality aspects of what we do. Thank you for everything you do, keeping us in track as well and reminding us. Thank you. All right, we have Dave. Are you out there? Dave, you might be double muted. *6.
Let me text him. I don't see him on here. But
I see Dave as guest.
Yeah, but he usually signs it as Dave Modoc. Let me text him real quickly.
Yeah.
And if you
Okay, well, you know what? We'll skip forward. Yep, we'll skip forward. And, oh, here's a question, Wanda, for you real quick. It says, it used to be nursing was in, let me go to the chat here. Sorry, guys. There was a question. Let's go to the latest here. Said nursing used to be in.
So it has to be a visit. The question is, does it have to it has to be a visit, that the visit has to be done. And anybody that's falling within the time frame that is actually PT, OT, speech, or nursing can perform the supervisory visit. Somebody that's familiar with the patient.
Okay, thank you. All right, well, we'll jump forward, and when Dave jumps on, we'll go back to his part. So just real quick, some home health rehab stats for everybody. Supervised visits just for, are the supervisory visits just for home health aid or assistance as well? We'll come back to that. All right, some rehab volumes are comparisons for 2023 and 2024. This is from Epic data in comparison with what we had. And it looks like we're doing well for both January, February, March. This is our total visits, and just from a home health rehab standpoint. So this includes OT, OTA, PT, PTA, and speech therapy. So I just kind of put them into a total. And it looks like we're doing well. We're actually doing a little bit better. The blue is 2024. So we're doing a little bit better than last year on our number of visits. So that's great. Thank you all for all the work that you're doing and seeing our patients and providing access. Just to let everybody know, there's a lot of open positions out there. From home health, we only have a few, so all full or part-time. OT, OTA, PT, PTA. Inpatient, outpatient, and then speech. If you're interested in any open positions, just reach out to one of the managers or myself, or even interested in learning more about perhaps like inpatient. I know some of the inpatient teams struggle a little bit for coverage. If anybody's interested in ever picking up any extra hours, you're saving up for your vacation, anything like that, I know inpatient is always looking for a little bit of help, even if it's after hours. So just reach out if you're interested in any way or want to know anything about open positions. You can go to the career site on the uhhospitals.org site as well to see any of the open positions. All right, next. All right, now this is the updates from some of our rehab meetings. All right, somebody put, you can't do PRN and inpatient while working home health. What you can't do, per our guidelines, you can't have a second position, but we can do floating through Chronos. So you just can't hold a second position. That was somebody's question in the chat about you couldn't do PRN and home health. You cannot hold two positions, but you can float. Updates. So this is coming from our meetings out in the markets, where I started getting out into the markets and meeting with the teams. So some of the updates, there were some questions about durable medical equipment, even walkers or canes that were being issued to people. You know, how do I find out who the vendor was? Sometimes I don't even know who did it. The patient, you know, wants to return something, or it doesn't, you know, the tub bench doesn't fit that they ordered through Care Transitions. This actually is going to be a fairly detailed project, honestly, from the inpatient side, because what happened when I reached out to inpatient and Care Transitions to find out, well, what are we doing from an inpatient standpoint when we're sending equipment home or ordering equipment for delivery to homes? So we found out that not everybody's doing that same process, and some may have different vendors even than they're using. From a community standpoint, community hospital standpoint to CMC could be very different. So actually we're getting a group together on the inpatient side to kind of discuss it But the request for us from home health, honestly, from our discussions was we really want that information. So I started out with asking them, can you in Epic put a line in the discharge from a care transition point, from the discharge, that says, this is the vendor we got the walker through, this is the vendor we ordered the bed and the tub bench through. So that's what we were requesting, but it really did open up a lot of more discussion. Just to let you guys know, when we're collaborating on these things, it really opens more questions a lot of times. So this is going to be an ask for the inpatient optimization coming from home health, because we just need to know who the vendors are. So hopefully that will make it a little easier for our patients and our team members out in the field once we get this added. So we'll let you know how everything's going, and once they put something into production when we get to optimization. But thank you everybody for bringing it up, because it really did bring up more questions even from the inpatient and care transition side. Another thing was clarification on putting subjective and assessment information. I know Dave is working hard on competencies and answering those questions, and I know he had some more information. Once he's able to get on, he had some more information to impart to you guys, so we'll go through that in a little bit. And again, thank you all for bringing that up. And then access to outpatient services. Just to let everybody know, some of the questions that came up in the markets were something like, when I call or help my patient call, or the patient calls, they get a recording, or if they get a person, it's not always consistent information. So working very hard to educate our team members, not our just PSRs at the desk, patient service reps, but also our team members in how to help collaborate on getting those outpatient appointments and getting our patients in and access to care. And then also talked about considering the rounds for physician education. And this might answer the other question that came up in the chat. So this is where actually we would have to work with Epic as well to be able to get a referral to outpatient services built in at the very front end of process. Hey, Dave, we'll get to you in a second. Going through the updates, and I'll go back to you then. Thanks. So the access to outpatient services, educating the doctors at the rounds and talking to them about how we can, in their orders and their order sets, start adding outpatient services for the ones that make sense at the very beginning. So that would mean they'd get an appointment for home health and outpatient at discharge. If outpatient had to change that appointment for whatever reason, at least they're in the system at that point.
I can get my volume to work. So is Wanda on the call?
Yep, Wanda's on. Education to access for the outpatient services. Any other ideas you guys come up with? And when I talked to the outpatient staff, they also brought up what we had already talked about, making sure too, when we pick up a patient in home health out in the field, that like visit one, when you're setting that frequency of 2 weeks, 3 weeks, talking to that patient, and if they don't have the information of how to get into outpatient, if you feel it's needed at that 2 to 3 week time period when we discharge home health, making sure they make that call right there at the front, not waiting till they're discharged. That'll help too, getting them into outpatient and access to services. So great collaboration, great ideas coming from the teams. We also have access to the physician protocols. So that's where I know Christina may be adding in here in a few minutes also, that, sorry, trying to read the chat at the same time here. Going back to access to outpatient services, no, it's a whole education piece. So no, we're trying to get much more consistent on outpatient, that when they schedule for PT, OT, whatever in the outpatient world, that they're not getting a message you have to be discharged. The message is really that we have to make sure we get our documentation done in home health for them to get into outpatient and it be reimbursed. So that's our part too on us, is making sure the documentation is completed from home health. Otherwise, somebody's going to get a denial. But we shouldn't be getting the messages from a PSR or a team member answering the phone in outpatient that they can't make a schedule. That's already been part of education to our team members here this month. Again, reminding them that they don't have to be discharged to make the appointment. They will have to be discharged to start. Yes.
Patty, this is Lori. I'm the one that put that in. I've had problems in the past couple of weeks with my patients. They've called, I tell them to call like the first day of home care, and they're getting told they can't schedule them until they've been discharged from home care and to call when they're done. So then I get on the phone and have to call. So that's been an issue that my patients are having. They won't schedule them as long as they're active with home care. I don't know
Yeah,
why it's so it's an
sorry. No,
education piece.
exactly. It's education. And as we all know, sometimes it takes a little bit to get through to everybody, right? So if you run into that, please let me know, because that means like there's maybe one or two offices not getting that message. So please make sure to let me know. If you send me a quick email, that way I can make sure that we're educating, because we don't want that message. We really want them to know they can schedule regardless. So thank you, Lori. No, I truly appreciate that. Let us know if you're running into that at any office, because we want to make sure we're educating all our team members. They should not be telling a patient that they can't get in. All right. Oh, go back. Hold on, Christina. Go back. Thank you. Go back. All right. Oh, yeah. Utilizing DWP. I know that Christina is going to do that in a few minutes. The access to the physician protocols or guidelines for like somebody that's had a total joint, or, you know, a reverse total shoulder with a bicep tenodesis, something like that. Those are available on the Rehab DWP. They're in the process of being updated. So Christina is actually working really closely with Diana Gabriel, and she's going to get a few extra members to help. It's going to involve on our DWP. You'll see probably some changes as we go along, but we're going to update all the MD protocols. And hopefully the end goal of this, that will probably take more than a year, is starting to get some of the physicians agreeing to like a broad protocol on certain things versus having a lot of different protocols. So more to come on that, but letting you know, you do have access to MD protocols and guidelines on our DWP. Christina, yes, is going to help with navigating the DWPs and show us a little bit of that. And she can help at any time. And I can as well. All right, now we have poll number 4, which goes to our collaboration. Let's see. There we go. So the opportunity, this is your poll, menti.com. If you're not on there yet, code 912-15737. The opportunity for communication between home health patient, inpatient, outpatient practice has improved over the past 6 months. So obviously this is something we've been working on. So has come up in our, engagement surveys about collaboration across departments. And hopefully we'll probably repeat this poll again in a few months. But it looks like some are neutral. Not really. I don't think it's improving. So yeah, if you have anything that can improve collaboration between our different practices, make sure that you bring it up at the market meetings if you don't feel, comfortable saying it like this kind of meeting. Make sure you bring it up at the market meetings too, or email, can work as well. So it looks like we're starting to move the bar a little bit. Wait just a minute and let's see if other people can get in here. So the question is the opportunity for communication between home health, inpatient and outpatient practices has improved over the past 6 months. Again, if you don't feel comfortable bringing something up in a big meeting, email helps. We want to make sure that we do collaborate across practice areas. And if you have a solution, make sure you bring that out as well. All right, we'll end that poll. Oh, there you are, Dave. Are you out there?
Yeah.
Wait, Dave, can you hear me? All right,
We can.
Hold on.
I'm in with Wanda and I couldn't get my speakers to work.
Do you have yours off? Because I have an echo.
Do you guys have an echo?
No.
Okay, so the Epic updates, can you turn that down? So,
Oh,
there you
we
go.
do
Okay.
have Epic now. We do have we do have
You
an
can
echo
hear me
right
now?
now. We can hear you with an echo.
Okay, so Epic Dorothy, April 2024 Rehab Forum updates here. We're just going to go through. So what we've been doing is recycling quite a few of the concepts that have been coming up since February. So now we're looking at, we're almost into 8 weeks now with some of these. And I just want to create some awareness, and we'll do this continuously. When we bring up a new initiatives or we see change, we'll continue to revisit those. So my apologies if some of these are already covered and you guys have seen them, but we want to ensure that we have everyone, on board. So the first piece, we're not going to go through addressing visits. I'm sorry, that slipped in there, but let's go ahead and slip to the next slide. So when the update came through, a lot of folks are seeing this through the competencies. We were spending a fair amount of time on the MedRec, and there's 2 SIGs that show. Now, SIG is as a reminder down there. You see this little box, or above the box, it says SIG is directions to follow by the provider to the patient for a given medication. SIG is not, it does not mean signature. It's actually a Latin word, but nonetheless, it means let it be labeled. So if a doctor prescribes something and it says let it be labeled as the patient should take metoprolol 25 milligrams, daily, and then, or I'm sorry, twice a day, then the patient says, well, I take that 2 times a day. So you can see in this screen here, when I say patient taking differently, that's a new SIG. So let's go to the next slide. So as you guys come through the competencies, we're going through medication reconciliation pieces. And one of the examples is how to state that a patient is taking something differently. So with this one here, we've actually said the patient now is taking this medication. They were supposed to take this metoprolol once by mouth in the morning. That's how the doctor prescribed it. So that's the doctor's SIG. So then we came along and we said we edited this by clicking the pencil icon across from the med, and we edited this by saying taking differently. So then when we come out here and we're looking at which SIG needs to go to the plan of care. So when you're doing your admissions, your research, your resumptions, we're selecting both. Just so that way we can say, hey, doc, now there's a conditions of participation that, we have to abide by, obviously. And, it says that we need to notify the provider, when the patient says they're taking a medication differently or they have some compliance issues and so forth and why. So this is our notification now to the provider, because on the plan of care, you will see that the provider SIG says that the patient should have it once a day. And then the patient's taking it differently. They're only taking it 3 times a week, and it's, due to the cost piece or whatever for that patient. So just wanted to bring that forward. So that's been an enhancement that came out a few Wednesdays ago. Let's move to the next slide. Now the home care addresses are now appearing in Rover. So in addition to the place of service address, your home care address will appear in there. And you can see this patient has a different home care address than their place of service address. Now, the place of service address should always be confirmed when you contact the patient. So this is not a bad place to call patients from when you're in your Rover device scheduling your appointments. Then you can ask the patient, and confirm their address. Now, irregardless of which address they tell you, you can hit the little globe there and it'll give you directions to that address, as well. So that's a new feature that came out so that way we have a little more clarity on where we're traveling to our patient. Thank you. Case communication available on Rover. So during your encounters, you know how you guys can document on flow sheets, you can document on care plans. Well, now you can add in media and photos. Now you can add in a case communication. And this is access that was just recently granted a few Wednesdays ago for a Rover device. And this will now show in your visits over on the remote client as a case communication form that's within the visit. So this is only downfall here is you can only use it if you're going to do a case communication during a visit. So if you're doing a missed visit or you're doing a home visit, then you can pull this new documentation in from Rover. Next slide. So the edit care team in Rover, this gives us a lot more flexibility and editability than the remote client. Remote client had some limitations. The Rover device now will permit us by selecting underneath the patient summary on care teams, you can edit the care team. You can actually add in care team members. You can end date care team members. So that's really nice. Say maybe I did the admission, I'm on the care team, but I'll never see this patient again. I'm going to pass it to, Sally Johnson, and then I can pull in, Sally Johnson and pass it along. Maybe I'm the case manager and I'm going to discharge my discipline. I can pass that case management over and I can go in and change that here as well. So it gives us a lot of flexibility. If you're self-assigning, and you say maybe work with a CODA or PTA LPN frequently, and you're circumventing the scheduler by assigning them visits. I know that happens a lot. So we understanding that piece of, we're adding this person to, assign visits. We also need to add them in for the care team. So you can do that as well. And then let's go to the next slide. So this just gives us an example from our case manager. I actually, edited this one here, and we're passing this over to Dakota, and you can see that I can put my end date in there, and then I can change Dakota, the PT, over as the new case manager as nursing has discharged this patient. So next slide. And then schedules are they've automatically synced from Rover. But this, just to bring awareness at the bottom of your screen when it's syncing, if you feel like you might have a time overlap issue and don't want to go down this rabbit hole of having this information go over to remote client and give you all kinds of warnings, you can stop the sync. So just a takeaway here, you can go ahead and stop the sync. All right, and then let's go to the next slide. And then Falls report on remote client. This is going to be an enhancement that is coming out. I know that, and this is a good thanks to, the advisory folks. They are also, instrumental in helping to shape our EMR now. And the advisory documentation committee has brought forward part of that's quality. We had some auth input. We also have, front end field clinicians in there, and they're determining, how to create some strategies and efficiencies. And one of the strategies for our patients that are being discharged or transferred into the hospital, they came up with this thought of, hey, let's have a thumbnail report that shows us when the patient had fallen, so we can fill out our J19, our 18 and 1900s. So in the thumbnail reports, this is going to be now available. So let's go ahead and go to the next screen. And then this was the, obviously the questions that you'll need to fill out. So that information will be at your fingertips, soon. So that way you don't have to dig through visit notes to see if the patient's had any falls. And that could be a daunting task itself. So let's move on to the next slide. So care plan intervention frequency, they're going to auto-populate to each, except for the supervisory visit one. The supervisory visit one utilized for the home health aide. Then we would do our supervisory visit is still going to be PRN. All the rest of our, in this example here, is going to populate automatically to each visit to prevent, multiple clicks that you guys have to do when you're performing your evaluations and initial assessments and developing care plans. So next slide. So here's an example also of an enhancement, speech therapy, care plan templates. One of the enhancements here is that the goals did not have an associated intervention. So now I can't remember which intervention, or I'm sorry, which goals it was, but there were some they didn't have an intervention to coincide with the goal. And the screenshot here just shows you that now it's going to come pre-selected. So if you don't want it and say there's several interventions under a goal, you'll have to uncheck it rather than check it. So that's another example of, how the documentation committee has been, enhancing and building some strategies for us. So we thank that group. Next slide. And I thank you all. So you guys, the feedback and the support that you guys have provided, especially the folks in the documentation committee, or any of the feedback that you've sent through emails, does not go unheard. These messages come to us. It does take some time. There is obviously some processes to go through to get the enhancements updated. We just have a hard time getting things done, as fast as we want to, but please hang in there and know that your messages do not go unheard. And we thank you for all your input.
All right, I think we got the poll done. All right, Christine is going to talk a little bit about navigating the DWP.
Okay, I've got a couple of poll questions that I'm going to put forth first.
So this is on that menti.com website. So would it be helpful to have virtual sessions on how to better navigate the DWP?
And these would be open sessions. Try to have one in the morning, one later in the day. And they wouldn't be mandatory.
So these would be sessions, Christina, that would be voluntary, and if you're having trouble navigating the DWP or just don't know, right?
Right. Okay, that's good. Good to know. And this should be one that you guys can fill in. So if you answered no or maybe, what would be the reasons or the barriers that maybe that you don't feel it's necessary? Which is that
I see it.
was one of the big things that I thought was going to be time constraints.
And somebody asked about how do they participate in the poll. If you go to menti.com on your phone, menti.com, use code 912-15737, and that lets you participate in the poll. Something new we're starting, so hopefully you guys find this helpful, that you're able to comment.
And I see somebody put in person better. So even if we do the Zooms as like open meetings, if you guys ever want to schedule any one-on-one with me, I'm happy to do that. I'm generally in the office on Mondays and Wednesdays.
And the poll code again for Menti, menti.com is 912-15737. 912-15737. We have a couple codes coming up, so.
So,
all right, so
I'm gonna
go
before I go on, I just wanted to get that kind of feedback to see if you guys felt like it was worth doing to help kind of navigate and starting to make that, like a natural way to look up stuff. So there is, even though that we have the rehab DWP for the outpatient, and there's a lot of information there too. On the home care rehab DWP, there is a page that is specifically for home care rehab. So some of the things that came to my attention were Ellen Garrett had asked about putting listings of modalities on there. And now with Marianne's work group coming into play, a lot of those files will make it accessible on the rehab page as well. I will add the list of the in-person meetings so that all of that will be on that page. And when Dottie was talking about the DMEs, that maybe we can also put DME contacts. Remember, this page is specifically for you guys in home care. So anything that you would like to see that is home care specific, please send in to me. And thank you for the feedback. And I'll be setting up some sessions in the next couple weeks so that we can navigate better in the DWP. Thank you.
Thank you, Christina. One of the things that has come up, some people have asked about, can they use ultrasound and e-stim in home health? So we thought we would explore that a bit more. So some of the questions, there's going to be a couple polls. No, this is not like the end of, the discussion or anything. We're really actually looking at seriously, is there any kind of evidence? So I have a couple of people helping, looking for evidence of modalities in home health and what might benefit our patient. So in other words, an example of that discussion about use of e-stim. We know that we have not provided e-stim or ultrasound for years in home health, although I believe maybe Parma or somebody on the west side had done it at some point and had equipment. We haven't done it in many, many years. Is it anything that we should really seriously think about adding for patient access to care? So we do have a look of evidence about those modalities. And, one example might be, our patients with our neuro patients, so post-CVA, is there any evidence out there maybe that the patient does benefit from earlier access to e-stim and neuromuscular reeducation? So just, letting you guys know that we're thinking about and exploring it, not that we can do it right at this point because there's a lot of steps involved. So honestly, it's not as easy as, just can I do it, because we have to add a standard guideline for home health if we do add that, from everything from, the competency, adding the competency for it, to the standard of practice or guideline for it, to how would we clean the equipment, right? All of that goes into, if Joint Commission is with us, they're going to look at those guidelines and are we following them? So, adding a modality, can be a little more complicated, but we did want to get input from people. So this is going to actually be part of our next ad hoc group, where we'll talk about some of the evidence, if there is much evidence. We don't know that. We're looking for the evidence right now. If there's a benefit to having certain types of modalities offered in home health. So we're actually looking at it, exploring it. We know it's not been historically a thing they've done in home health recently, but it doesn't mean that would not benefit our patients if we can find that evidence. So more discussion to come. It'll go to ad hoc group, but we did want to talk about it, and we did want to bring it to the group. We did want people's input. So remember, we're always looking for our field clinicians' input. So here is your input for today at a poll is, if you're on menti.com, menti.com, code 912-15737. The question is, do you, each person out there, I believe we should include ultrasound and or e-stim as an option for patients in home health. So it's yes, no, or not really sure. I need more evidence. Maybe that's the question on that one. So should we include it? I believe we should, or no, I don't believe we should do e-stim or ultrasound in home health. Just not sure. Leave that open for just another few seconds. Again, we want everybody's input if possible. And again, this will be more discussions coming forward, but we want to make sure that we have input into these discussions. Again, it'll come to ad hoc. So the ad hoc committee, if you want to be involved in these discussions, let me know. Or Joe Green's a member of the ad hoc, Joe Yonner. So let them know if you have some input on this, if you don't want to join, any committee meetings. All right, we'll end the poll. All right, then, okay, I believe home health patients should be transitioned outpatient should they need ultrasound or e-stim modality. So this might be the people that said, yeah, no, go to outpatient, right? I don't know. We're asking. I believe home health patients should be transitioned to outpatient services should they need ultrasound or e-stim. Yes, they should, or no, maybe we can do this in home care, or at least start it, or unsure. We'll leave that up a little bit more, maybe another 10 seconds. There's a comment, I believe it would be beneficial, would need to be accompanied by education and competencies. Absolutely. That's part of anything we add. Ken's down there saying circumstantial. Yeah, I mean, it could be specific patients. So I think that's where the I don't know, right, is we're looking at the evidence. So is it something that, should it be in home care, or nope, we don't want to do this in home care? I believe it should just go to outpatient. That's the question right now. And Tracy's asking, are there patients that can't leave home, right? And would they benefit? Good question. There you go. So these will all be great questions. We'll bring this, hopefully get some of these comments and questions into our discussion on our ad hoc group. So thank you, everybody. Thank you for participating too in the slides today, in the polls. All right, next slide. All right, just a real quick on Rehab Career Ladder. Next slide. There's been some updates and clarifications, just so you know. We have ongoing discussions from an inpatient, outpatient, home health standpoint about the career ladder. So there were some questions. So clarifications are making sure everybody knows there's a May and a November application period for the career ladder. If you're working, and the career ladder is available information on the DWP. So anybody needs that direction, let me know. If working on steps and a plan, so maybe I don't meet the criteria to elevate right now, maybe I need to work on a plan with my manager. Okay, so then you would reapply the next period, the next application period. So if I don't think I quite meet in May, well then I'm going to reapply in November because I'm working on a plan. If you do reapply in November, just as an example, you would not need to obtain new references if within 12 months. So your references are good for 12 months. Criteria elements. We've had the question, does a candidate need to meet every element of a criteria that's on those career ladder fill-ins? No, you don't have to meet all of them, but you do need to have some objective data. All right. Please reach out if you have any questions on the career ladder. Let's go next slide. Oh, we are 1 minute past. I apologize, guys. And this is just, we can go quick, Christina, through these slides. I just left in some examples of the career ladder that are on the DWP and then the needs that you have to fulfill. So next few slides will be available to you online about education coming up. We have some planning. We have nothing yet out there for registration, but we do have a PEDS course coming up in September. We have planning going on for basic vestibular and neuro symposiums and a couple of others. So as soon as we have any registration plans, I will let everybody know. And anybody on the education committee can let anybody know as well. And I know Christina's great about posting it as well. So thank you, everybody. We'll go ahead and end this. Any of the education pieces, and there's free courses at the end of the PowerPoint, that will all be available to you online when we post this. So thank you all for participating today. Thank you for jumping on the polls. Hopefully we kept you interested in what we were talking about. And thank you to everybody that did some updates today. Truly appreciate everybody getting on and helping out. All right, everybody, thank you. Thank you very much. This PowerPoint will be posted on the DWP probably by tomorrow. I'm going to stop the recording right now. Again, thank you, everybody.